Much excellent talk. We proceed with Matthias Hilty. He's from Switzerland. He works also in intensive care medicine. We did several expeditions together, and he will talk about high altitude pulmonary edema. After this, we have time for questions.
Well, thank you, Urs, for the introduction. I'm going to speak in English. I'm very glad to be here in Argentina. It's my first time. My home country is Switzerland. I represent the Swiss Society, or the Swiss Alpine Club, in the medical commission of the UIAA, but I work, as Urs said, in the ICU at University of Zurich. So we have heard a lot by Eduardo about the physiology in hypoxia, which is very interesting physiology. We have heard how the body adapts to hypoxia to counteract the effects and be able to survive at high altitude. But in the end, there is things that can go wrong. In this process of adaptation, things can go wrong, and that's when we develop high altitude illness like AMS, like Hape, or pulmonary edema, which we will now talk about. So it's a very simple origin. We have already seen that. The barometric formula is behind everything we're going to talk about. It's one factor. But in the physiology, it has so many effects that we still are learning every year more about how we adapt and how this can go wrong. And this we have already seen also very nicely by Eduardo. So above about 2,000 meters of altitude, hypoxia plays a role. And we can induce adaptation when we expose ourselves to this altitude. And we have also seen that when we go higher to extreme altitude, and this is an arbitrary limit, but it's around maybe 6,000 meters, where we actually cannot adapt when we have acute exposure, but then we will lose consciousness and we will eventually die. And this adaptation, it enables us to survive in this environment for days to weeks. We have heard from Eduardo. And even if we go higher in the death zone, commonly referred to about above 8,000 meters, we can even survive there in the short term. But we have to be sure it is not a place where we can adapt long term. So there will be, this thing called altitude deterioration. It does not enable us to survive for a long time. And already we are now a bit in the subject, what can go wrong during this adaptation. And there are two main things, two categories of pathophysiology that can go wrong. And I have heard we have about 50% of you that have a medical background. So my goal is to, if we talk about pulmonary edema, it's kind of an abstract thing. I don't want to just talk about the symptoms. I want to give you some basic understanding of what actually goes wrong in the body so that we develop pulmonary edema. And first, we have heard AMS. This is one of the big categories of disease that can go wrong. AMS is related to inflammation, to tissue edema, and it will cause all of those very diverse symptoms that we have heard before. And then there is this second big thing, and this is the pulmonary edema. The pulmonary edema has a completely different mechanism. It is not really related to what happens in AMS, except, of course, for the origins where it all starts. We have seen in AMS, the worst case is the development of cerebral edema, high altitude cerebral edema. This is the absolute emergency. We have heard what to do if this is the case. And in high altitude pulmonary edema, it is more of a binary decision if you are on the mountain. If you decide that your patient or your comrade has Hape, it's no question anymore what to do. You do the full treatment and you go down. So it's very important to be able to to detect those symptoms and also to differentiate from the other things. You see here on the radiogram of the lungs, you see this edema. This is the fluid that goes out of the pulmonary capillaries into the tissue. And this is what prevents us from breathing, and it prevents the oxygen from entering the blood, and that's very, very dangerous. So again, these two forms, if we look at AMS, we said it's inflammation, it's something that goes wrong with the permeability of the blood vessels, where they try to keep the water inside of the vessel, but no, the blood vessel does not work as it should, and water goes out of the vessel, and you have this tissue edema and the inflammation. This all happens in the blood vessels of the systemic circulation. All of your organs are perfused by the blood that is pumped by the left side of your heart into the arteries, and that's how the oxygen goes, of course, into the tissue. And on the other hand, you have a whole different blood circulation in the lungs. This functions very differently. If you look at the lungs, you have the alveoli, that's where the air goes in and has very close contact with the capillaries that go through the lung. And the big difference here, the pulmonary circulation, it does not have much in common with the circulation of your systemic organs. Because you have to think, your left heart pumps the blood through all of the organs, liver, kidney, everything, the brain, the muscles. And the same amount of blood per time, it goes at the same time through one single organ, and that is the lung. It goes in parallel through the lung, and the right heart, it's a different part of the heart, pumps the blood through the lung, and the circulation has to have very different properties to accommodate for that. This is not something that you have to learn by heart, but it really just shows what the lung can do for the circulation. Imagine if you go, you sit here, you have a cardiac output maybe of 4 or 5 liters per minute per square meter of body surface area. And you can easily, if you go outside in the mountains, you do some sports, you can easily increase that 5 times. And the lung, as a single organ, has to take all of this blood volume per minute and 5 times as much in a single organ. So it's really amazing what the lung can do. And the thing is, the pressure in the pulmonary arteries, it does not really increase that much while it accommodates all of that blood flow. So the vessels are very flexible. If you put more volume, the vessels will dilate, they will recruit the capillaries, and you don't have really an increase in blood pressure. And the right ventricle, this is the right part of the heart that pumps all of this blood through the lung. It basically is not made to work as hard as the left side of the heart where you have a high blood pressure. So it's really, those are the important things. And if you look, we have seen from Eduardo, if you look what happens to the circulation when you adapt to high altitude, there is not really a very much interesting stuff going on, because heart rate, stroke volume, even the blood pressure in the systemic circulation, it may go up a little bit, may go down a little bit, but that's not really what makes you adapt. We have hinted this in the morning, but what makes you adapt is that the body is able to increase the density of the capillaries in the tissue so that the oxygen can go into the tissue, because you have less oxygen available. So this is the important thing that happens there, and this is also where the AMS thing goes wrong, because in the capillaries, something goes wrong and the water goes out into the tissue. But that's not the subject for now, but we're going to look at the lungs, and also Eduardo has given us a hint here. He has told us that the blood pressure in the pulmonary artery increases when we go to high altitude. And that's, you already know, it shouldn't happen, because in the pulmonary circulation, blood pressure would stay quite constant no matter what we do. But if we go to high altitude, it will increase. And that is because the lung has this mechanism where if one part of the lung does not work, the vessels constrict, and the blood goes to the parts of the lung that still work, which is very nice, because that's how you survive pneumonia. That's how our ancestors survived pneumonia and didn't die because some part of the lung didn't work. But if this happens to all of the lung, because we are in hypoxia, in general hypoxia, all of the vessels constrict and we have hypertension. And this is basically what's behind the pulmonary edema story. And it was not always clear how this worked out. And we have a bit of a tradition in Switzerland and to do high altitude research in laboratories. So this is the Margarita hut. Maybe have any one of you been to the Margarita hut? of course, very nice. It's the highest building in Europe. It's at 4,500 meters. Really good view, but the problem is people go there in 1 day, usually, or in 2 days. They all have AMS. Some of them have Hape, and that's really great because it's really hard to study Hape. You don't see a lot of pulmonary edema, but here you do, so it's great. We go here and we see that. And my mentor, Marco Maggiorini, maybe you've heard of him, he has, this is history, this is 2001. He has basically looked at the pressures in the capillaries of the lungs when they go to the Margarita hut. And he has really shown that if this increases, then you get Hape. So he has proven Hape is really a question of blood flow. It's different than AMS. It's not inflammation and those things. So that's how we know what Hape is. And just to show you a little bit, it's not that complicated in the end. HPV is what we call this this vasoconstriction that we talked about. So pulmonary artery pressure goes up, but there is a slight difference. It's not the same in all of the vessels. So there is an inhomogeneity. And this inhomogeneity will increase the pressure not only in the arteries, but also in the capillaries. Those are the really small vessels where the oxygen enters the blood. And if this happens, we have a pressure gradient to the tissue, and the water is pressed out like in a coffee machine. It's pressed out of the bloodstream into the pulmonary into the pulmonary tissue. And this is Hape. This is pulmonary edema. So this is what could go wrong. And we do have a protective mechanism that protects us from having Hape, because otherwise we would all have Hape when we go to high altitude. And this is just has been discovered in 2016 in the humans. This was a other study that we did in the Jungfraujoch, which is another of these huts in the Alps where you can go and take some healthy people and do some examinations. And we found that there is really remodeling of the pulmonary vasculature that protects us from filtering this water out into the pulmonary tissue. So this is how we get Hape. And Hape, you look here at the CT scan. So this is a cross-section through the pulmonary tissue in a computer tomography. You see it's not homogeneous, and this is exactly what we have said when we talked about how it comes into existence. So you have these patches of edema, and that's where the vasodilation is less than in other parts and where the increase in the capillary pressure happens and you really get the water out. So in the end, it just fills up your lung with water, and that's not a good thing. It will, by definition, give you 2 or more of these 4 symptoms and 2 or more of the findings. So it's dyspnea at rest. People, they don't move, but they still have difficulty breathing because the lungs are full of water. There is cough. There is pressure in the thorax. But the single most important feature that you have to recognize is that if someone suddenly does not perform anymore, he just feels very tired and he's not even able to continue with the pace that you were walking before. So this is really the thing you have to look for. And already you see, when you have suspicion of Hape in some of your colleagues on an expedition, this is the point where you need to get medical expertise. You need to consult with your doctor that is with you, or even by radio. And then it's also important to get those examinations. So you need to check with the stethoscope the lungs. If you hear the rails, you need to get the vital signs and really assess if Hape could be a problem. So again, with the computer tomography, it's a bit of a nicer image. You see this patchy, this patchy infiltrates in the lungs. So how often does it happen? I said before, it does not happen very often. So basically, in a general population in the Alps, it's very rare. It's less than 1% that have ever experienced Hape. But that's what I said. If you go to the Margarita hut in a quick ascent, is really the best way in the Alps to experience Hape. You do get this in, still 4 to 6%. It's not very rare anymore, especially if you go very quickly. But there is another factor, and this bit similar to the AMS. There are people that are more susceptible to Hape, and that's in the way that their pulmonary vasculature reacts to the pressure. And if you have people that are susceptible for Hape, you see here, you have a 10-fold increase in risk. So this is really what you have to identify when you go with a group to high altitude, if some people are susceptible. We get back to that later. So it's not that much that you have to know to prevent and to treat high altitude pulmonary edema. So I put here the Hape in the bottom, next to the AMS, which we have already seen in the previous talk. What do you do to have prophylaxis and treatment of AMS? And here you have the thing for Hape. So the important things to prevent the occurrence of high altitude pulmonary edema is to know your group, is to know if some member is Hape susceptible. And Hape susceptible is really, it's the easiest thing you could do to find that out, because the really one factor that determines susceptibility is if this person previously experienced Hape. Then a person is Hape susceptible. Obviously, if someone has never been to altitude, you cannot know. And that's one of the problems. There are a lot of physiological studies that try to find in a different way. It's possible, but it's very invasive and it's not very easy to do. So usually you just have the history. But that's already quite important. So if you have someone that has experienced Hape in the past, first thing you have to do is you have to really find out if it's a good idea to go again. But oftentimes it's not a problem if you do the right thing. And doing the right thing would mean you decrease your ascent rate even more. We have heard 300 to 600 meters per day would be recommended. So you really go to the lower end of that. 300 meters per day increase in sleeping altitude, and it's only the sleeping altitude that matters. It does not matter if you go to a peak in between. And then there is the medication. So for this, you will obviously consult medical advice, but it really cannot hurt to distribute the knowledge so that you have all seen and heard what is actually recommended. So there are two kinds of medication that lower the pressure in the pulmonary circulation, and those are recommended. Either one of them, it really doesn't matter which one. One is much less expensive than the other, so you can decide for yourself to take one of those. The less expensive one, it does have a bit more side effects, like hypertension in the blood pressure of the systemic organs. So that's how you prevent Hape. And it's really important to know it's not the same people necessarily that are susceptible for AMS that are also susceptible for Hape. So you have to really ask the history of your colleagues. And if you find these red flags, if you then see the symptoms and the findings, you consult with your medical support, and you determine that someone has Hape, it's really it's one of the most emergency situations that you can have in high altitude. So the only goal you have is to get this person down. Because the good thing is that if you have high altitude disease, if you go down, it resolves. But the problem is, sometimes it's hard, and that you know very well, to go down, to get someone down that cannot move anymore. So the treatment goal, you get medical treatment, and the goal of your medication is to enable this person to go down, and you have to do that while he can still do it. That's really everything you have to remember. Of course, you give oxygen. You can use a Gamof bag. You need to give sildenafil, Viagra. This also decreases the pressure in the pulmonary circulation. And only if you have also symptoms of AMS, but I must say this will most likely be the case, then you would also give dexamethasone in that case. And the most important thing is really the descent. So this I will touch just very briefly because it's really cool. There is a new type of high altitude disease that has been recently discovered. So this was not known before. So this is why medicine is so important, so interesting. It was in young soldiers in the Indian Army that were brought to 6,000, 5,000 meters in the border to Pakistan, and they stayed there for several weeks. They were completely healthy. Some of them developed failure of the right heart. not the left heart, but the right heart. You will remember this is the weaker part of the heart that only needs to pump the blood through the lungs. And it's actually quite easy to explain now that we know that there is this mechanism to prevent high-altitude pulmonary edema in our physiology. Because it will prevent edema, but at the same time, it will increase the workload for your right side of the heart. And this is the reason that the poor young soldiers in India had this right heart failure, because of their protective mechanism for Hape. So you see a little bit, these things are really all related, and the good things can also be the bad things, but they're still necessary. And to finish, this is the Jungfraujoch station, where we did this study with the remodeling. And just to show it really goes on, we still really know very little about all these things. So what we just studied is the advanced way that these mechanisms regulate the pulmonary pressure. And one thing that has not really been known so far is the effect of the autonomic nervous system. This is the kind of nervous system that regulates your body function without you knowing it. And we found that they play an important role also in this regulation of the pulmonary pressure. So it's not over yet. Of course, we have a lot more mountaineers that have high blood pressure, have heart disease, they're older, they still go to the mountains, and they have medications that could play a role here. So the take-home message is similar to AMS. Please prevent. Please know the history of Hape and AMS, of people you go to the mountains with. So the previous severe AMS, previous cerebral edema, previous pulmonary edema, those are the relevant things. Previous mild AMS is not a problem. That happens to all of us. You have to decide, should he go again, should she go again, or then you know how to prevent, as we have seen. You think about Hape when you are in the mountains, because the symptoms can be deceiving, and you have to find out early, and you have to consult your medical support early. And when you have diagnosed Hape, you treat, which means do not ascend further. So the dexamethasone question, for me, is very clear. If you ever use dexamethasone, you never go up again. You just go down, and you go down as long as you can. Because if you cannot go down anymore, that's when the only way you could die in the Himalayas is because you don't go down. Descend as soon as possible, finish the talk as soon as possible. And the medical measures only enable you to go down. Thank you for your attention.